think without further ado, I'd like to introduce Jane O'Brien, as I said, the convener, who's done an amazing job. Jane is a specialist breast and oncoplastic surgeon whose practice is exclusively confined to breast work, encompassing assessment, diagnosis and treatment of all benign and malignant conditions of the breast, as well as surveillance and prophylactic surgery for high-risk groups. Her areas of special interest are in oncoplastic surgery aimed at maximising the cosmetic result following breast conservation surgery for breast cancer, using advanced surgical techniques and nipple-sparing mastectomy, as well as reconstruction, both in the preventative setting and as treatment for cancer. So once again, very warm welcome to you all this morning, and I'd like to introduce Jane. Thanks, Jane.
Thanks, Gary, and thank you all for coming. In selecting benign breast disease as the topic today was really in response to the fact that benign breast disease is common, much more common than breast cancer, and tends to be somewhat overlooked when we're talking about topics for this sort of presentation. I'd like to thank the Epworth staff, as Gary said, reiterate Gary's sentiments, Amanda, Christie particularly, and Michaela and Madeline for organising the event, and for Daniel for coming in at the last minute to videotape the event. The event will be videotaped and edited later, so that may or may not be available for you to view subsequently online, and the evaluation for the meeting will be available subsequently online. So as I said, breast cancer is common, but benign breast disease is commoner still, and anxiety about breast disease is very common. 47% of a sample polled about their attitude towards their breasts in the UK admitted to being very anxious about their breasts, and 62% who were anxious about developing cancer, 40% of them were actually in an age group where cancer is very uncommon. More than 90% of women who present with symptoms will have a benign problem rather than cancer, and it is therefore important for everyone involved with women with any sort of breast symptom, whether it be in a clinical capacity, in an imaging capacity. I know a lot of the delegates today have an imaging background, are familiar with benign breast disease, so that patients are appropriately reassured, appropriately treated if necessary, because benign breast disease does cause considerable anxiety. And effective treatment, I think, includes not only making an accurate diagnosis and excluding cancer, but there needs to be an adequate explanation of the condition. And I think it is important to provide patients with relevant information, and there is a lot of information on benign breast disease, which I know a lot of people do provide for their patients. So basically, when a patient presents with a breast problem, the question for the general practitioner initially is there a chance that a cancer is present, and if not, am I able to manage these symptoms myself? The investigation of any breast symptom requires the diagnosis or exclusion of breast cancer. Every single patient who presents with a breast symptom, in the back of their mind, irrespective of their age, fears that breast cancer may be the underlying cause. The cornerstone, really, of assessing breast symptoms is this triple assessment of breast symptoms. It is regarded as such an important key underpinning principle that when Cancer Australia recently, last month, released a landmark statement on 12 practices which they'd identified as appropriate or inappropriate for the provision of breast cancer care in Australia, one of those 12 statements was, as outlined there, it is not appropriate to confirm or exclude a diagnosis of breast cancer without undertaking the triple test, which involves taking a patient history and a clinical examination, some form of imaging tests, and some form of biopsy. I'm just going to put on a short video that summarises that, if we could.
The Cancer Australia statement, Influencing Best Practice in Breast Cancer, provides the evidence to support effective patient-centred cancer care and improve cancer outcomes. The statement is based on the best available evidence, supported by expert clinical and consumer advice.
There are nearly 16,000 new cases of breast cancer in Australia every year. More than half of these are diagnosed as a result of investigating a breast change.
When I discovered a change in my breast, I placed huge trust in my doctor to be able to accurately confirm or exclude a breast cancer diagnosis.
And that places a huge responsibility on us GPs to get it right.
Women and doctors need to be aware of the triple test when investigating a new breast symptom.
So the three things that make up the triple test are, firstly, taking medical history from the patient and doing a clinical breast examination. Secondly, ordering a diagnostic mammogram and or an ultrasound. And thirdly, making sure that an adequate biopsy is taken.
The correct sequencing of the tests and correlation of the results with the breast symptom is important to the overall interpretation of the results. If any part is positive, that is, if it's indeterminate, suspicious or malignant, it needs further investigation or specialist referral.
If it's done properly, the triple test has over a 99% chance of finding breast cancer if it's there.
Which is why it's not appropriate to confirm or exclude a diagnosis of breast cancer without undertaking the triple test.
For more information on the Cancer Australia statement and key appropriate and not appropriate breast cancer practices, visit canceraustralia.gov.au.
So as I said, 95% or 90 to 95% of breast symptoms are not due to cancer. More than 50% of breast cancers diagnosed in Australia are diagnosed as a result of a patient presenting with a breast change or a breast symptom of some sort, and the GP is normally the first port of call. The GP therefore initiates the triple test by taking the history, performing a clinical breast examination and ordering appropriate imaging. This, which was made available by the then National Breast Cancer Centre in 2006, is freely available on the Cancer Australia website and is not out of date. The principles underlying triple assessment have remained the same over years. Some of the investigations and some of the practices have changed, but the basic philosophy of the triple test remains the same. Clinical examination and history, imaging and biopsy. And as we heard on the video, the triple assessment is positive if any component of the triple test is indeterminate, suspicious or malignant, and a positive result means that further action is required. The aims of triple assessment are to maximise diagnostic accuracy, both of benign and malignant breast conditions, to maximise the preoperative diagnosis in breast cancer, thereby avoiding unnecessary diagnostic biopsies for breast cancer, and also, if possible, to minimise excisional biopsies for diagnosis of either cancerous or benign conditions. A patient may well decide to have a benign breast lump removed. However, if a benign diagnosis is able to be established with a preoperative investigation, the patient can make a decision themselves as to whether they go ahead with that procedure. Any benign biopsy operation can potentially place the patient at a poor cosmetic result, and one of the commonest causes for litigation in breast disease is a poor cosmetic result after benign disease, whether that be because of a poor incision or poor technique. And even with the recommended incisions that we would generally subscribe to with benign breast surgery, primarily being periareolar infomammary or incisions off the breast at least, you still can, due to poor scarring, on occasions get a poor result. And therefore, I think it is better to avoid the obligatory need to do an operative procedure for diagnosis if you can. So, as I said, all palpable lumps require full triple assessment, irrespective of the likelihood of the patient having a cancer, which is obviously age-related. So, by the age of 25, there's only a 1 in 11,000 roughly chance of developing breast cancer. However, that does not mean that someone in their 20s should not have full triple assessment. About 6% of breast cancers occur under the age of 40, and yet benign breast disease is very common in that below 40 age group. And again, that still means every patient who has a palpable lump requires a diagnosis to be made. The completion of the triple test is multidisciplinary with the clinician, the GP or the breast surgeon, the radiologist and the pathologist. And the key really is the review of all the symptoms and the correlation with the presenting symptom. And one clinician has to take responsibility for that correlation. As we heard in the video, the sensitivity of the triple test is around 99.6%. That means a woman who's got breast cancer, the triple test will detect that cancer in 99.6% of cases. So the likelihood of there being a cancer present, if the triple test is negative, is extremely low. Summarised in another way there. What details are needed in history? Well, usually it can be a fairly brief history with a breast symptom. The sex of the patient, obviously, the age, family history, personal breast history, reproductive history, probably including hormonal treatment and or IVF treatment, and previous breast imaging and documentation of all of the above. The clinical breast examination, I think there are various techniques described. I think for each individual doing clinical breast examinations, the important thing is to adopt a consistent approach and to document the findings. And I think it is worthwhile considering using a 1 to 5 classification in the same way as cytology, 1 being normal, 2 benign, 3 indeterminate, 4 suspicious and 5 malignant for documentation purposes. Having done the clinical examination, a woman is then referred for breast imaging. Any woman with breast symptoms should be referred to a diagnostic imaging service rather than to a breast screening service. Screening mammography is for patients in the appropriate screening age group who are asymptomatic, and as anyone here in the audience who works in an imaging department or a screening service understands, often the radiologist doesn't view the films at the time of the screening. The radiographer may look at the films, but the radiologist doesn't necessarily read the films until the patient leaves the department. In a diagnostic imaging service, in theory, the patient will have the films looked at by a radiologist before they leave the premises, and additional workup views and or further imaging in the form of ultrasound may be arranged. Routine mammography, as you're all aware, is 2-view, craniocaudal and mediolateral oblique, and the issue about compression is a real one for women. I think with the new digital mammography machines that the compression is less of an issue, and I think women are complaining less about the discomfort with compression with the newer machines. But I think it's important that the clinicians do reinforce to patients that compression with mammography is a required part of the technique in order to get the best view mammography. And as I said, at a diagnostic imaging assessment centre, there will often be some form of workup at the time, including perhaps ultrasound. What tests to order? Ultrasound should be the first imaging modality if the patient is under the age of 35 arbitrarily and during pregnancy and lactation. If the ultrasound is frankly suspicious, I think mammography should be added irrespective of the patient age. For women 35 and above, I would ordinarily order mammography and ultrasound. One of the difficulties with the accuracy of mammography in younger women is this issue of breast density, and as a general rule, breast density on mammography can't be predicted by examination of the breast, but it is more common that the breasts are dense in younger women and in women who are either breastfeeding or using HRT. However, many women remain mammographically dense throughout their life. The sensitivity of mammography is much greater in women with fatty, not dense breasts, with the accuracy going down significantly in younger women with dense breasts, with a false negative rate of up to 50% in younger women. And fairly obvious example here with a cancer in a fatty breast, which obviously you're going to find difficulty identifying in a dense breast. Both clinical examination and mammography increase in sensitivity as the patient ages. Digital mammography, which is available virtually everywhere at diagnostic imaging services these days, has multiple advantages over conventional analogue mammography, and we'll talk about imaging again. One of the speakers is going to talk about imaging a little later in the morning. Most services have gradually begun to introduce digital breast tomosynthesis, and again, we will talk a little bit more about that later in the morning, but it is another significant advantage, particularly in women who may have mammographically dense breasts. Breast ultrasound is useful for the evaluation of breast symptoms in younger women, a palpable abnormality, further assessment of a mammographic abnormality or a second look ultrasound after an abnormal area has been detected on MRI, and certainly after surveillance after any form of breast surgery. There's not a great deal of evidence to support the use of breast ultrasound as a screening phenomenon, although there has been some work in younger women. Just looking at a case here, 24-year-old, no family history, a palpable lump, feels benign, ultrasound reported as query fibroadenoma. This is really to underline the fact that irrespective of the patient age and the appearance on imaging, a tissue diagnosis is required in every patient with a palpable lump, triple-negative cancer, depending on patient age groups. A lot of surgeons now have an ultrasound in their rooms. This is not a substitute for diagnostic level sonography, and all patients would receive a professional ultrasound as well. It is useful in the rooms to differentiate between solid and cystic lumps, and primarily to confirm that the palpable lump that the patient's feeling and the surgeon's feeling corresponds to any imaging abnormality that's been seen on formal imaging. It's not a substitute for a formal diagnostic quality radiologist-reported ultrasound. Ideally, we would like to see synoptic imaging reports with a 1 to 5 classification preferably. It is helpful in interpreting the reports, and it is something that should really be universally provided. Breast MRI we would not regard as part of the standard workup of any breast symptom, but is often useful in women who've undergone triple assessment in whom the results may still be a little discordant. Patients should be provided with information, preferably before they have a biopsy. They're often nervous, they think it's cancer, even the young women, and a lot of what's talked about during the consultation may not be taken in entirely. The needle biopsy part of the triple assessment takes in a fine needle aspirate, or more commonly these days, a needle core biopsy, which allows histology and a more definitive diagnosis. The beauty of core biopsy in benign breast disease diagnosis is if a definitive benign diagnosis is established, such as fibroadenoma, it not only establishes a diagnosis, it confirms unequivocally that the lesion that's been targeted has been sampled correctly. Cytology, you may get a benign result, but you don't have definite proof that the lesion that's been targeted has been sampled. So just once again, the triple test, about 99.6% sensitivity. The sensitivity of needle biopsy is 90% by itself, which may seem lower than expected, but again, that may be due to a targeting error. Another example, 32-year-old Chinese girl, no family history, a palpable lump left breast, ultrasound, query fibroadenoma. Core biopsy, benign breast disease. Now, benign breast disease may or may not cause a lump, but you cannot necessarily accept benign breast disease as an explanation for a discrete lump and a discrete general practitioners. Diagnostic delay is the most common cause of litigation for medico-legal negligence in the USA, and there's no doubt it can be reduced by strict adherence to triple assessment. One cautionary note here, just before I finish up, I think the patients with whom the most care must be taken in some ways are the patient who complains of a lump, but the clinician is not impressed by the clinical findings. That is the one circumstance in which I follow those patients carefully. It's the second most common scenario in medico-legal payouts. The patient thinks there's something there, you can't feel anything, there's nothing on imaging. I think those patients need to be followed, because if they subsequently develop a cancer in that area, they're going to think that it was that initial lump. To finish up, I think the patient needs to have clear communication regarding the risk. After full triple assessment, if it's a benign outcome, it needs to be explained to the patient that if the lump is not excised, there is a tiny chance that there is a cancer, but not high enough, probably in most circumstances, to justify removal of the lump. And I think a fail-safe method for recall and follow-ups is very important. Thank you.